So till here we discussed. Now coming, we discussed the pathophysiology of shock in various scenarios. Okay, now coming to the clinical part of it. So the first part was actually more of a build-up. Okay, just to give you an idea of what are the challenges of the cardiovascular system in the newborns. Okay, and then maybe now we are coming to the clinical part of how to manage shock or how to diagnose shock. Okay, so before, I mean, one part of the challenge is to diagnose it early. Okay, I mean, होता क्या है कि eventually shock is picked up early morning 6 a.m. 7 a.m. जब some senior resident comes for a round, and uh, by the time we start intervening, it is already too late. The child is in an irreversible phase, and then we keep thinking कि भाई क्यों बच्चा survive नहीं हुआ, or why was a bad outcome. So because it was picked up late. Okay, so the challenge is to pick it up early, to pick it up in time. Okay, and to prevent the bad outcomes. Okay, so clinical diagnosis, as far as clinical diagnosis is concerned, so there are many ways by which you can, I mean, diagnose shock. One is tachycardia, okay, which very commonly, every day in day-to-day practice हम देखते ही हैं कि there will be tachycardia, there will be a prolonged capillary refill time, there will be some central peripheral temperature difference. Okay, the peripheries will be cold, the core body temperature will be maintained, so central peripheral temperature difference will be there. There will be a reduced BP, decreased sensorium, there will be decreased urine output, metabolic acidosis with the raised lactate, and the color also will be, cyanosed or dusky, whatever you say. Okay, so there are some 7 8 different ways जहाँ पे हम clinically diagnose कर सकते हैं. Now, the question is, or the challenge is, which of these to rely on more? Okay, which one to choose, which is better than the other? Okay, so coming to the, as soon as we talk about shock, the first clinical thing which comes to our mind is CRT. Okay, I mean, eventually CRT हमारे मन में ऐसे बैठ गया है कि shock मतलब it is prolonged CRT. Okay, so let us see what this CRT is. Okay, so capillary refill time, actually it is nothing but the time required for the return of color after application of blanching pressure to the capillary bed. So the study which I have quoted here is actually an old one from 1999, but still it holds relevant. And this CRT, usually of CRT of 3 seconds, is something which we take as an upper limit of normal. But there is significant inter-observer variability. ठीक है ना? I mean, CRT prolonged for a first year, CRT maybe 2 seconds. जब थर्ड ईयर उसको देखेगा तो he will say CRT is 3 seconds. जब AP देखेगा तो he will say 4 seconds, and जब HOD देखेंगे तो it will be 5 seconds. Okay, so there is inter-observer variability. We do not, I mean, sometimes, I mean, it is, based on the level of experience of the person who is measuring it, the interpretation will vary. First thing. Second, based on the site of measurement also, there is inter-observer variability. Okay, so what this study, which was done in 1999, what it found is that if it is measured on the chest, it is still more reliable. But when it is measured on the forehead, palms, or heels, CRT is not that reliable. Okay, so kai baar, even in my rounds, I feel when if somebody remembers, when I was in rounds, people will tell me, sir, CRT is prolonged, and then they will show it to me on the sole. Okay, so that is not reliable. Okay, CRT should be measured on the chest, but even with that, also the reliability is questionable. And there was a meta-analysis which was done a few years back, and this meta-analysis, I think it was published in 2014 or something. And what this meta-analysis, it actually includes all the children, including newborns. So what they found is, whenever CRT was used, so what they found is, whenever CRT was used for detecting serious illness, the sensitivity was only 34.6. Okay, so it has a very low sensitivity. Specificity is quite good. It is 92.3%, but the sensitivity is quite low. So what does it actually mean, or what is the interpretation of this finding? That it is a specific sign. Specific sign means a prolonged CRT should worry you. If you have a child who is having a prolonged CRT, you should definitely be worried. But at the same time, a child with normal CRT doesn't mean that he doesn't have shock. Okay, so it has got a low sensitivity means, so all those who are in shock will not have a prolonged CRT. There may be quite a few where the CRT is normal, but still the baby has poor perfusion. Okay, so our CRT thing is not very reliable. You have to, you cannot rely on it totally. Okay, then coming to the blood pressure. Okay, one thing when I was there, we were not giving much of importance to the blood pressure. Okay, we usually rely only on CRT, heart rate. We see कि residents will call me that sir tachycardia hai, CRT is prolonged, it is shock and we are treating. Okay, we don't take the pain of measuring blood pressure, which is very wrong. Blood pressure needs to get some due. So blood pressure, in other units, if you see, especially in some good units, they are using blood pressure cutoffs for diagnosing hypotension and treating babies with shock. But again, there is a problem with blood pressure also. It is not flawless. The problem with the blood pressure is it becomes low, the blood pressure becomes abnormal only in uncompensated phase of shock. Okay, so I told you there is something called auto regulation. Because of that auto regulation, क्या होगा कि जब भी when the child is in compensated shock. So when the child is in compensated shock, I think there is some disturbance. Yeah. So whenever the child is in somebody is unmuted, there's some disturbance. So whenever the for BP to become abnormal, if you pick up a child who is in hypotension, you are already late. Okay, the child has already entered uncompensated phase of shock. Compensated phase will be missed most often. On the other hand, the problem with BP is that what we measure routinely in our units is actually non-invasive BP. Okay, हम जो measure करते हैं that is non-invasive BP. Ideal is in invasive BP. If you have a sick child, the ideal or the gold standard is invasive BP. But again, the problem with invasive BP is for that we need a central or peripheral umbilical radial artery catheter, and it is associated with its own technical difficulties and procedural complications. NIBP is something which we can use on the bedside. It is simple to measure, but the problem with NIBP is it is poor. It has poor reproducibility. Okay, so एक बार आप measure करोगे, it will show hypotension. Maybe the next time when you measure, just after 5 minutes, the blood pressure will come normal. So the reproducibility thing is poor with NIBP. And second is there is lack of validation against the standard. So standard is invasive BP. There are not many studies which have validated NIBP as compared to invasive BP. Okay, so these are the two problems why blood pressure may not be very reliable, but still we should measure it. I'll tell you why. So this was a systematic review which was published in 2021 in the Journal of Pediatrics, and they studied the different methods for BP measurement in neonates and infants. So, I have purposefully kept this slide just for our residents to learn which is the ideal cuff size for a particular baby. Okay, कई बार when I used to ask residents to measure BP, होता क्या था, बहुत ही छोटा cuff जो जैसे तैसे tightly बांध के जैसे तैसे BP लेके I will be informed. Okay, so that is not reliable. Your cuff size should be appropriate. How do you decide what is the appropriate cuff size? For that, this is the width. Okay, this black line which you are seeing where I have kept my pointer, this is actually the width of the cuff. Okay, and the width of the bladder cuff, it should be 0.5 centimeters of your mid-arm circumference. Okay, it is written in down also that जो बच्चा का mid-arm circumference है, उसका 50% should be the width of the bladder length. Okay, when you are measuring BP with such a cuff, only then it will be reliable. Okay. So this is one thing which you have to keep in mind. One thing you have to start using BP whenever you have a sick baby and you are treating that baby for shock. Please start using blood pressure values. Okay, start measuring blood pressure values for such babies. And when you are measure it with an appropriate size cuff. Okay, that is why I will be telling biomedical people to give new cuffs every time. Okay, so because this is very important. And one more thing is, this even the guidelines are there for the International Neonatal Consortium to measure BP in the neonates. So what they say is right upper arm is the best site for measuring BP. Okay, it is less reliable when it is measured in the left upper arm or maybe in both the lower limbs. As compared to that, the right upper arm is actually the best thing. And also, the non-invasive BP is not very reliable when your mean arterial pressure is less than 30. Okay, so agar you have a baby who is in shock and you are measuring BP and your mean arterial pressure comes to be less than 30, your NIBP values are not very reliable. Okay, because below this, for very low BPs, the sensitivity is not good. Secondly, what they tell, the last sentence is very important, कि किसी भी बच्चे में एक single value of BP is not very important. What is more important is the trend over a period of time. Okay, I will be more interested in what is the trend of BP over a period of time, not a single value. Okay, so that is very important. So nowadays, all the machines, all the multi-para monitors which we are using in our NICU, they have the capacity, or they have the ability to show you a trend of BP. Okay, I mean, I'll not be worried with a single value, but if the BP values are persistently on the lower side, then it should sound an alarm to you. Okay. So then, what is the definition of hypotension? I mean, all said and done, सबसे बड़ा controversy is, I mean, what do you call hypotension? किस value के नीचे अगर BP जाएगा तो you call it hypotension. Okay, so there are three different definitions which are used in many of the studies. If you go and search the literature, there are thousands or lakhs of studies till date in the past 30-35 years, जिसमें बहुत सारा, they have taken different cutoffs of BP for different gestational ages. The three most common definitions which they have used is, first is a mean BP which is less than gestational age in weeks. Okay, so which means what? If I have a baby who is 30 weeks of gestation, so agar for that baby, if the mean BP is less than, if the mean BP is less than 30, then I will treat it as hypotension. Similarly, if my baby is 34 weeks, then the target BP will be, target mean pressure will be 34. If my mean BP is less than 34 for a 34-week baby, I'll treat it as hypotension. One thing. Second definition, which is more commonly used, is irrespective of the gestational age, any BP, any mean BP which is less than 30 mmHg should be treated as hypotension. Why? Because what some of the studies claim is कि जो ऑटो रेगुलेशन जिसकी मैं बात कर रहा था इनिशियली, दैट ऑटो रेगुलेशन फेल्स एट अ मीन बीपी ऑफ लेस देन 30. ओके, सो एज सुन एज योर मीन बीपी गोes below 30, your brain circulation and other circulation to the vital organs starts getting compromised. So that is second thing. And third definition is that they have prepared some charts for lower centile of BP, that is fifth centile. Okay, there are many charts. If you go and search the internet, some 10 different charts are there. One is a Zubro's chart, second is McNamara's chart, third is Dion's chart. So there are different authors who have prepared their own charts. उन्होंने वो चार्ट कैसे प्रिपेयर किए हैं? They have conducted an observational study of babies with different gestational age who are not having shock, and उन babies में if suppose there are 100 babies, so they have plotted BP of 5th centile, 50th centile, and 95th centile. So whenever your BP is above the 95th centile for the gestational age, you call it hypertension. Whenever it is less than 5th centile for the gestational age, as per their cutoff, then it becomes hypotension. Okay, so there are many charts for it. So of these three, this first thing, mean BP less than gestational age in weeks, is very arbitrary. It is just based on expert opinion and not evidence based. So this is not used now. Less than 30 mmHg may be used, but what we prefer more often is to use the gestational age specific centile charts. Okay, again, there are many charts. One chart which we used to follow when I was doing my DM is this McNamara chart. Okay, so these values, I mean, you see there is gestational age, then there is systolic BP, mean BP, and diastolic BP. Okay, so what this is actually nothing but the lower limit of normal. This is actually the 5th centile. So for a baby who is at 30 weeks of gestation, if his systolic BP is less than 43, if his mean BP is less than 29, or if his diastolic BP is less than 20, then I should be worried. If his diastolic BP is sitting at 24, 26, I will not be that much worried. Okay, so this was about the blood pressure and the blood pressure cutoffs. Okay, then coming to the other parameters which I listed out initially. One is the core periphery temperature difference or the central peripheral temperature difference. Okay, so the central peripheral temperature difference is based on the assumption that whenever a baby is in thermoneutral environment, okay, जब भी कोई baby if he is in thermoneutral environment, poor perfusion is associated. It is because of vasoconstriction and decreased skin temperature. Okay, so the central peripheral temperature difference of more than or equal to 2 degrees Celsius is considered significant. Normally, in a normal baby, the difference between the temperature on the abdomen and the foot should be less than 1 or equal to 1. But if it is more than 2 or equivalent to 2, then you should be alert that there is something abnormal. Okay, provided the temperature should be normal. Okay, so that is what I have said. It should be in the thermoneutral environment. Okay, however, this method has got a very low sensitivity and specificity. When it was studied in this study, which was done way back in 2004, what they found is the sensitivity is only 40%, specificity is only 69%. Okay, so that is quite low. Then one more parameter which we use is metabolic acidosis and elevated lactate. But so elevated lactate and metabolic acidosis usually happens whenever there is anaerobic metabolism. Okay, so the problem here again is that by the time you pick up anaerobic metabolism, by the time you pick up an elevated lactate and metabolic acidosis, your child has already entered into maybe an irreversible phase, and maybe you are quite late in diagnosing it. Okay, so that is one problem. Second is the specificity is 60%. Sensitivity is quite good, but the specificity is low. What do you mean by that is how do you how do you infer it is that there may be many other conditions where you have a metabolic acidosis or elevated lactate, like an inborn of metabolism, which will present in the newborn period. Okay, so you never know that whether it is actually because of poor perfusion or because of some underlying metabolic disorder where the lactate is raised. Okay, so that is why this is also not very reliable. Then coming to urine output, usually in adults, and I mean even in pediatrics, when you are managing patients with dengue, you are more about urine output, right? हर रोज हम जाके एक ही चीज पूछते थे pediatrics में वार्ड में जाके dengue patients में भी urine output कितना, because we are more about worried about the perfusion there in terms of urine output. But newborns में the decreased urine output may not be a reliable marker for hypoperfusion, because especially in the initial 1 or 2 days, all the newborns have physiological oliguria. Okay, the kidneys are immature, the filtering capacity is immature, the GFR is low in the initial 1 or 2 days. So because of that, anyways, in the initial few days, the urine output is less. And if I have a baby who is having poor perfusion, I will not be able to judge it only on the basis of a low urine output. Second is, even if the urine output is okay, sometimes what happens is the urine output will be okay, but still the perfusion will not be proper because of the renal tubular immaturity. Okay, so even normal urine output may be associated with uh, poor perfusion. Okay, so that is why urine output is also not reliable. And lastly, coming to the skin color, again there are many factors which affect the skin color, like the thickness, oxygen concentration, oxygenation, and all. So again, it is not reliable. ठीक है, तो I mean I discussed some 7-8 parameters till now, and the conclusion is that none of them is reliable. ठीक है, so the gold standard is actually functional echo. Okay, functional echo is actually the gold standard for diagnosing and managing shock on time, but there is a problem that it is not available universally. Second is it is skill dependent or operator dependent. ठीक है, even at this stage I may sometimes not be very good in doing an echo for some of the babies. Some babies, yes, I may be able to pick up, but I mean, I'm not a pro in doing echo for all the sick babies. Okay, so that needs experience. Okay, it is something skill dependent. So again, functional echo has its own limitations. Okay, so after discussing all this, ultimately the question is, what should we do then? I mean, everything is not reliable, everything has its own limitations. Then what should we do? So I remember, I am reminded of this gentleman who once in a speech he told कि अगर हम करें तो करें क्या? I mean, what should we do if everything is not in our hands? Then what should we do? So there is partially an answer to it. This was the article which was published in 2020 in the European Journal of Pediatrics. And the good thing is it was done by an Indian team. Okay. I mean, the group of neonatologists, they are from Hyderabad. Okay. This is the team from Fernandez Hospital, Hyderabad. They have done a study. And I mean, they have proposed that clinically, if you want to diagnose shock, since all the parameters individually they are not reliable, we can use them in combination. Okay, and so what they told is that you can take a group of six parameters, and if at least two of those six parameters are abnormal, you can label the baby as having shock. Okay, so what they told is a heart rate of more than 180, a decreased BP which may be less than 30 mmHg, or a BP which is less than the fifth centile for the gestational age, oliguria of less than 0.5 ml per kg per hour in the preceding 6 hours, a CRT of more than 3 seconds, a core peripheral temperature difference of more than 3 degrees Celsius, and metabolic acidosis with a base excess of more than -5, or lactate more than 2 times the upper limit of normal. So, I mean, taking together, these are the six parameters. So, if any two of these six criteria, if they are present, we can label the baby as having shock. Okay, and I mean, I feel this is actually a good way to diagnose shock clinically. I mean, the best is to have an echo, but again, I mean, practically speaking, her unit mein echo is not possible, and sometimes in a busy unit like we had in Adani, sometimes, I mean, even if echo was possible, I didn't find the time to do it for all babies, right? So in that case, if you have like, I mean, this is something I would recommend you take a printout of it and post it or paste it in your NICU, and keep in mind that if any two of these six things are there, you label the baby as having shock and start treating. Okay, so that is one thing. Then coming to the management part. Okay, so I mean, one part of the problem is we have diagnosed shock. The other bigger challenge is now how to manage it. Okay, so there are three ways to practice medicine. Whenever, I mean, we are practicing medicine, there are three ways to do it nowadays. I mean, you would have heard that everywhere the concept is we have to practice evidence based medicine. Okay, everybody is behind evidence based medicine. If you come to super specialty, your exam will start with evidence and your exam will end with evidence. For everything and anything, they will ask you what is the evidence for it, what is the evidence for that. Okay, so I mean, nowadays we are all behind evidence based medicine. Okay, that is one thing. Second way of practicing medicine is physiology based medicine. Okay, so there are certain areas jahan pe evidence is not very good. Okay, and in those situations, when till the time we get a good evidence, what we rely more on is physiology. What is the underlying physiology of that disease, and based on the physiology we manage. And थर्ड थिंग इज एम्पिरिकल मैनेजमेंट कि जैसा हमें ठीक लगे या जैसा हम परसीव करें वैसे हम उसको ट्रीट करें. ठीक है, सो दीज आर द थ्री वेज बाय विच वी प्रैक्टिस मेडिसिन. Unfortunately, as when we talk about neonatal shock, there are not many RCTs available because of the nature of the disease. Now, shock is a medical emergency, right? And I mean, if you know that a child is crashing because of shock or because of hemodynamic instability, you cannot, spend time कि भाई नहीं मैं तो इसको RCT में involve करूंगा और देखूंगा कि इसमें dopamine चालू करना चाहिए या dobutamine चालू करना चाहिए, because it is a one thing is it is a medical emergency. Second is there are ethical concerns. I mean, you cannot conduct a study at the risk of patient's life, right? So, I mean, because of the nature of the disease, it has not been possible till now to conduct many RCTs. If you go and search the internet, there will be many studies where they are comparing dopamine with dobutamine, or they're comparing epinephrine with dopamine. There are 100,000 different studies, but if you see them technically, there are many pitfalls. There are many limitations in the way the studies were designed or the way they were conducted. So till date, there are not many good RCTs to guide the management of shock. That is one of the limitations. Second, what we were doing, I mean, what was the practice till now कि we were more on protocol based empirical protocol कि भाई अच्छा ठीक है prolonged CRT है शॉक है चलो पहले बोलस दे दो फिर डोपामिन चालू करो फिर डोबुटामिन चालू करो फिर एपिनेफ्रिन चालू करो एंड लास्ट में ultimately the child will go. Okay, so that empirical protocol based management is again associated with poor short term and long term outcomes, as was seen in this study which was done in 2021. Okay, so again now the people are moving from empirical management, protocol based management, empirical management to something called a physiology based management. Why? Because we don't have the evidence right now. Okay. So the third part is definitely not doing any good. First part हमारे पास में available नहीं है. So what we are left with is physiology based management. Okay. So the take home message from today's talk will be that whenever you are treating shock, always think what is the underlying pathophysiology, and based on that you decide the management. Okay, so I mean, that is, as I said, we are now moving from empirical management to a physiology based management. Okay, and so coming to the first thing, I mean, the age old tradition was that as soon as we diagnose a baby with shock, we'll go for a fluid bolus. Okay, so let us see how reliable it is to give a bolus, or how useful it is to see to give a fluid bolus. So it is, as we all know, it is the traditional first line therapy. Okay, as soon as we see a baby with shock, first thing we do is sister bolus api do 10 ml per kg. Okay, so I mean, let us see how reliable it is. But I mean, usually fluid bolus is indicated only in those scenarios where there is actually an evidence of fluid loss. Okay. So see, suppose you have a baby who has birth asphyxia. He was born through meconium stained liquor, and because of this intra or in utero hypoxia or in utero insult, he is asphyxiated, and because of that, he is in shock in your NICU. So if you think properly, there is no place जहाँ पे blood loss हुआ हो, ठीक है? तो बेबी का जो वॉल्यूम ऑफ ब्लड था वो तो वैसा का वैसा ही होगा. देन व्हाट, आई मीन, वेयर, व्हाई डू यू थिंक कि बोलस विल हेल्प? ओके, आई मीन, लॉजिकली थिंकिंग, वहां पे कोई ब्लड लॉस तो हुआ ही नहीं है, ठीक है? आई मीन, द चाइल्ड इज इन शॉक बिकॉज ही हैज पुअर मायोकार्डियल कॉन्ट्रैक्टिलिटी, बट उसका इंट्रावास्कुलर वॉल्यूम इज good. So why do you want to give a bolus? And if you give the bolus, if you increase the intravascular volume, again you are causing more strain on the already compromised myocardium. Okay. So the role of bolus is only in those scenarios where there is actually an evidence of hypovolemia, or where there is an evidence of fetal blood loss, as in case with antepartum hemorrhage. So antepartum hemorrhage, what happens is the blood loss which happens in antepartum hemorrhage is actually a fetal blood loss. Second is when there is cord avulsion, or maybe a cord prolapse with cord compression. So in those scenarios, actually the blood supply from the placenta to the fetus is compromised, and because of that, there is hypovolemia. Okay, so in those scenarios, that is why I used to scold the residents. Okay, I want a proper history, because until and unless you know the history, your management will not go proper. So if you have a history of something like an antepartum hemorrhage, or a cord avulsion or cord compression, in that case, you may go for a fluid bolus. Otherwise, there are other animal studies which have shown that, giving a fluid bolus, it results in a minimal change in the cardiac output. It does not help much in improving the output of a compromised myocardium, and it also does not increase the cerebral oxygen delivery. Okay, so it is actually not doing any good. Rather, the increased fluid bolus is associated with increased morbidity and mortality. Okay, so that is why, I mean, fluid bolus is something, I mean, if the residents who have worked with me, I will not be, much in favor of giving fluid boluses very often. Okay, there may be certain situations where I would tend to give a fluid bolus, but not very often. So a practical point is that if you have a doubt that there may be hypovolemia, then in that case a 10 to 20 ml per kg bolus may be given if you feel necessary. And if after that bolus also, if you feel that there is not much of response, it is better not to waste time on a second bolus. You go ahead with pharmacological management in the form of vasopressors or inotropes. Okay. Then coming to the cardiovascular drugs. So cardiovascular drugs, we loosely call them inotropes, but there is a difference. Okay, there are certain drugs which have a predominant vasopressor action, there are certain drugs which have predominant inotrope action, and there are certain drugs which have both inotrope and vasopressor action. So predominantly vasopressors are dopamine, norepinephrine, and vasopressin, whereas the predominant inotropes are dobutamine and milrinone, and with both actions are epinephrine and hydrocortisone. So these are actually the doses and the mechanism of action. I'll not go into the detail. I will share the PPT so that you can keep it as a reference. I think, but everybody of us knows the mechanism of action of most of the drugs. The one which I will specify or which I will put emphasis is on the effect of hydrocortisone. So there was always a controversy जब मैं अदानी में था. I mean, always the residents used to ask me कि why so much I am interested in giving hydrocortisone. So, I mean, the hydrocortisone acts two ways. Okay, it acts at the level of sympathetic nerves. So this side it is the sympathetic nerves, and it acts at the level of vascular receptors. Okay, so it acts both the sides. So in the nerve terminals or in the nerve endings, what it does is it will inhibit this enzyme catecholamine O methyl transferase. This enzyme को hydrocortisone will go and inhibit. So what this enzyme does is it causes the conversion of norepinephrine and epinephrine to metanephrine, that is inactive metabolite. So when you inhibit this enzyme, what you are doing is you are increasing the concentration of norepinephrine and epinephrine at the nerve terminals. So that is one way by which hydrocortisone acts. Second is it decreases the capillary leak, which is happening in babies with shock, in septic shock. Okay, I mean there were people. I mean some residents, you used to ask me that sir, septic shock hai, should we go for a hydrocortisone? Hydrocortisone is known to decrease the capillary leak which is happening in these babies, and on top of it, it increases the glucocorticoid receptors, it increases the mineralocorticoid receptors, it increases the availability of intracellular calcium. So by all these mechanisms, it helps in getting a good response to all your inotropes which you are giving in addition to hydrocortisone. Okay, so then coming to the management in specific conditions. Okay, in different pathophysiological conditions, what will be the clinical findings and what will be the management? I'll try to go a bit fast because we are less in time. So, if you are if you are dealing with a baby who is having a transitional hemodynamic compromise, that is, there is problem for the baby to transition from in utero to ex utero environment, mainly seen in extreme preterms or very preterms, your 1 kg babies, 800, 900-gram babies on day one of life. If that baby is having shock, it is not septic shock, it is mainly because of this transitional hemodynamic compromise. So usually what why it happens is because of the low myocardial contractility, poor vasomotor tone, increase in the afterload, and also these babies have some degree of relative adrenal insufficiency. Okay, because their adrenals are immature. So as a result, they will present with a normal to high diastolic BP because your systemic vascular resistance is high, the afterload is more. So there will be high diastolic BP. There will be a low systolic BP because the contractility is low. So since systolic is low and diastolic is high, the pulse pressure will be narrow. And what are the drugs you have to use? So in this situation, if you use dopamine, already he is having a high afterload. If you add dopamine, it will even worsen your afterload. Okay, so in these conditions, I need a drug which causes peripheral vasodilation. So afterload भी कम होगा, and on top of it, it increases the myocardial contractility. So definitely dobutamine is the drug of choice. So a baby extreme preterm on day one of life having shock, most likely transitional hemodynamic compromise, dobutamine is the drug of choice. Second, if you feel dobutamine is not acting much, you can go for a low dose epinephrine. And if these two drugs are also not able to give you an adequate response, last is hydrocortisone because these babies are known to have adrenal insufficiency. Second is, if you have a baby with PDA, hemodynamically significant PDA, the systolic BP will be high, the diastolic BP will be low, and there is wide pulse pressure. And eventually, in later stages, when the LV failure happens, even the systolic BP will decrease. So management will include closure of the ductus arteriosus. There is you have to have permissive hypercapnia and increase PEEP. Okay, so if you are keeping the baby on CPAP or ventilator, increase the PEEP from 4 to 5 or 6 because that increased PEEP will cause increase in the pulmonary vascular resistance. It will decrease the shunting happening at the level of PDA. And if at all you feel that your LV is failing and you need a inotrope, then dobutamine is the drug of choice because it will increase the systolic performance of the heart of the failing your left ventricle. Okay, again in babies with perinatal asphyxia, what you see is there is a low systolic BP because the myocardial contraction is low. The pulse pressure will be low because your systolic BP is low and diastolic BP will be normal. So again, the drug of choice here will be dobutamine because your contractility is low. You don't want a drug like dopamine or norepinephrine, which will increase the systemic vascular resistance and it will again worsen the myocardial heart load. Okay, so you go for dobutamine or low dose epinephrine, or you, if both of them are not responding and you have a biventricular failure, that is your LV and RV both are failing in advanced stages, then you can go for milrinone. Then coming to PPHN. So PPHN usually presents with hypoxemia, and there will be low systolic BP because the inflow to the LV will be low, and so there will be low systolic BP, there will be low pulse pressure, and the diastolic BP will be normal. Okay, and eventually in later stages the diastolic BP will fall, but usually in the initial stages, if you pick it up, the diastolic BP will be normal, systolic BP will be low. So, and again, the management is primary. You have to go for sedation, you have to ensure optimum ventilation, you have to go for pulmonary vasodilators like sildenafil. And if you are not able to get a response with that, then maybe you can go for dobutamine or milrinone, because both of them will cause pulmonary vasodilation. They will decrease the systemic vascular resistance also, so the afterload on the LV will be less, and on top of it they will help to increase the LV contractility. So that is why these are the preferred inotropes. And if last stage, if there is low diastolic BP, then as a last resort you can add vasopressin or maybe a noradrenaline. Okay, in babies with sepsis, they usually present with low diastolic BP, normal pulse pressure, and the systolic BP may be normal or increased, and there will be tachycardia. Later stages, when the myocardium is also involved, there will be combined systolic and diastolic hypotension. So management is basically antibiotics, volume expansion. So here in these babies, definitely you need to give a fluid bolus. Okay, and then it is in these babies only you go for a dopamine or a vasopressin or norepinephrine, depending on how severe the hypertension is. In later stages, when the myocardial contractility is also compromised, I'll go for a norepinephrine or hydrocortisone. Now, why hydrocortisone? Again, to answer that query again, see, this was the surviving sepsis guideline, which was published by the European Society of Intensive Care in the year 2021. Okay, not very old, just 2 years back it was published. And in their guideline also, what they have told is that if you have a baby who is responding to fluid resuscitation and vasopressor therapy, you need not to use hydrocortisone. But if you have a baby who is not responding to adequate fluid resuscitation and vasopressor therapy, means you have given fluid resuscitation, you have given norepinephrine or dopamine, and still you are facing low BP or you are facing the cardiovascular compromise, then in those cases you can consider giving hydrocortisone. Okay. Then in babies with infant of diabetic mother, so usually there is asymmetrical septal hypertrophy, there is diastolic dysfunction, LV inflow will be poor, and so in these babies also volume expansion will be the first line. Uh, Again, you should not use inotropes like dobutamine or milrinone in these babies because they will worsen the shock. And vasopressin is the drug of choice because it increases the preload and prevents straining on the heart. So this is the chart which I think you can take a printout and keep in your NICU as a bedside guide whenever you face a baby with shock. So if all these signs are present, you label the child as having shock. Then you see whether hypotension is there or not. If there is hypotension where the systolic BP alone is low but diastolic is normal, then these may be the causes. If diastolic BP alone is low, then these may be the causes. If combined, then these may be the causes. I think, ma'am, we can put one more link if possible, just to discuss the queries of the residents, because I am done with the talk. These are the therapeutic endpoints. So if a baby is there with shock, when will you stop considering the treatment? When all these things are there, that your BP, everything is normalized, extremities are warm, peripheral pulses are good, CRT is less than 2 seconds, and echo is normal. So I think with this I'll stop. And I mean, for questions, if we can take a separate Zoom meeting.